All right. Welcome back to our second edition of the Lightning Talks for this event. Dr. Colleen Reid is back to moderate this session for us. Again, for anyone who wasn't here, she is an assistant professor in the geography department at the University of Colorado, Boulder. Her research focuses on the health impacts of exposures influencers by global climatic changes and society's responses to those changes. So I'm going to go ahead and hand it over to Colleen.
Thank you. Yes, welcome to our second Lightning Talk session. This one is focusing on health impacts. And because we want to give the most time to our speakers, we are going to get started with our first speaker, Kelly Perry, whose talk is titled Proposing an Integrated Framework of Health Impacts of Wildland-Urban Interface Fires. Actually, one thing before we let Kelly get started, if you have questions, please put them in the Q&A, and then after each talk, I will ask those of the speaker. Go ahead and get started, Kelly. Sorry, I interrupted. You should go for it.
No, you're so good.
Kelly, I don't hear you. I think you might be muted.
Can you all hear me okay?
Now we can. Why don't you start over?
Okay, will do. Sorry about that. Hi, everyone. Thanks so much to Cafe for having me. Today, I'll be proposing an integrated framework for understanding the health impacts of wildland-urban interface, or WUI fires, based on some ongoing research my team at Duke and the University of Hawaii at Manoa are working on. As previous presenters have already touched on, wildfires and WUI fires in particular continue to grow in frequency and intensity. We need a clearer picture not only of the physical exposures people face, but also the psychological and social dimensions that shape health outcomes. Next slide, please. We already know that ambient air pollution and wildfires can influence mental health, but far less is known about WUI fire-specific exposures. These events involve unique chemical mixtures, like previous presenters have touched on, and the stress and trauma of a disaster specifically. So a key challenge that we're facing is how do we distinguish the biological effects of inhaled chemicals from the psychological impacts of trauma and risk perception? And what does this mean for estimating the full health burden of WUI fires? Next slide, please. To address this question, we propose a framework that combines two pathways. First, the physical effects of chemical inhalation, so looking at systemic inflammation, oxidative stress, and downstream impacts on both physical and mental health. And second, the mental health effects of the fire itself. This is trauma, risk, fear, uncertainty, and the role of risk perception. One more click, please. So we already know that the air pollution exposure and wildfire exposure can affect physical health and mental health, and that psychological perceptions can independently influence well-being. But in the context of a WUI fire, these pathways overlap. For example, the questions we're asking are, is anxiety and depression driven by biological toxicity, by awareness of the smoke, by the disaster experience itself, or all of the above, and how might mental health then feed back into physical health? Next slide, please. To better understand these linkages, we are conducting a scoping review with our primary research question being examining the public health and environmental impacts of WUI fires across air, water, and soil, and our secondary question asking what is known already about resulting health effects from inhaled smoke and ash to pollutants in water and soil to the secondary impacts of experiencing the fire itself. Next slide, please. To illustrate the complexity of the questions we've been asking in our study, I invite you to consider a neighborhood where two residents are exposed to the same levels of pollution. One closely follows the news and knows the toxic risks of the pollutants, and the other is more unaware. So, can awareness alone, without any difference in exposure, affect anxiety or depression? And how do we distinguish this from trauma-related impacts of a wildfire? Next slide, please. This leads to the central idea behind the framework we've been thinking about, which is that there are two exposure pathways operating simultaneously. The first pathway involves perceptions, expectations, and beliefs. This includes the quote-unquote nocebo effect, where negative expectations, for example, negative expectations related to a wildfire can create tangible symptoms like inflammatory responses in the body that then interact with this second exposure pathway that is biological. So the biological effect of the pollution itself, inflammation, oxidative stress, and systemic health impacts. So overall, we are understanding more and more that mental health in wildfires requires acknowledging that both pathways can operate simultaneously. Next slide. Advancing the field of looking at wildfire research requires combining exposure data that previous presenters have touched on with perception measures through surveys on perceived pollution or stress. We know that awareness links to stress, socioeconomic factors, and information access, and can influence behavior like choosing to stay indoors. So this really highlights the need for more mixed methods research that integrates epidemiology and social and behavioral science. Next slide. To summarize our key takeaways, pollution can affect mental health through both biological pathways and psychological ones. And right now, next slide, we are currently conducting a study in Lahaina, Maui, that builds on what I just discussed, looking at both mental and physical health effects. And my last slide then just shares a hypothesis that we are trying to better uncover primary and secondary damages related to physical and mental health. And my last slide, please. Thank you.
Thank you so much for that talk. I'll remind everyone who's listening that they can put their questions in the Q&A. I'm going to just start with one since I have one. I really liked how you laid out these different hypotheses. I wonder if with the data that you're collecting, you can also look at, like in that neighbor scenario, other potential pathways, right? So you could have someone, as you mentioned, whose awareness could lead to behavior change that is protective, and therefore less physical exposure, because you said that these could have similar exposure, they'd have the same exposure. And I think we often forget in this work that individuals make their own decisions about not just staying indoors, but in wildfires, evacuation, self-evacuation, not because being told to, because of the chemicals and or use of masks or other sort of protective gear to protect oneself from ash and as well as airborne exposures. And if you could look at that, as well as, I also loved the respiratory leading to mental health, or the mental leading to sort of respiratory conditions, or like, does it exacerbate? Can you follow up over time and see if there's individuals where it gets worse or and not just leading to a different health outcome?
Absolutely. Thanks so much for that question, Colleen. And that's exactly what we're thinking about. We know that these issues don't happen in a vacuum. And as we're asking these questions, as we're collecting data, we have a kind of like similar to a case control study that previous presenters have touched on. We have the cases of families, so looking at both parents and children ages 8 to 14 who were exposed to the wildfire in Lahaina, compared to families upwind, if you will, who did not get exposed to the fire in Lahaina in August 2023. And as we are talking more and more to communities, we know that, like you said, to protect communities, we're not just trying to at the end improve the air people breathe, but also how people interpret and act on information about that air, whether they choose to stay home, whether they can stay home, and how they share information and information access around that air is a really key area that I think is underexplored. And I think previous presenters, Dr. Jen Stowell and Sienna as well, touched on mental health issues and wildfires being the new frontier in wildfire research, if you will. I think making sure that mental health and physical health is integrated in studies that look at wildfires is really crucial, because there is that trauma component of when forests burn down. It's a totally different thing compared to when your house or your car is burning down. So those kinds of social, systematic issues really need to be taken into account as well.
Great. Thank you so much. I think we'll move on to the next speaker, but please take a look at the Q&A if questions come in for you. And our next speaker is Lanxin Song, whose talk is titled Unequal Burdens, Wildfire Smoke Exposure and Birth Outcomes in California.
Yeah. So good afternoon, everyone. Today I'm going to present our findings from a population-based study. Well, first of all, just a little bit background. We all know that wildfires have accounted for up to 25% of PM 2.5 in recent years across the U.S. And in some Western regions, it's up to 50%, especially in California. And pregnant individuals are particularly vulnerable because of both physiological and psychosocial stress. So our goal was to quantify the association between wildfire-specific PM 2.5 exposure and adverse birth outcomes, and to test whether this affects weather across demographic groups. Next, please. Yeah, okay. We analyzed 4.75 million births in California throughout 2011 to 2020, each geocoded to the maternal residence address and then linked to a daily wildfire-specific PM 2.5 estimate data source at 10 by 10 kilometer spatial resolution from Dr. Child's study. And we modeled the exposure across entire pregnancy and then by trimesters and by weeks, and focusing on preterm births, low birth weight, and small and large for gestational age. And then we used stratified analysis and interaction analysis to examine the EMMs. Next, please. So overall, we observed consistent evidence that wildfire smoke exposure increases the risk of preterm births, and more substantially for more severe preterm births, and the risk also climbed sharply at higher exposure levels. We also used additive modeling, and the curves revealed steep nonlinear increases in risk beginning around 0.05 microgram per cubic meter. So basically, there's no really safe threshold. We also found the second trimester to be the most sensitive window. Next, please. These effects were not uniform across subpopulations. When we stratified by race and ethnicity, we found that non-Hispanic, Asian, and Black mothers experienced stronger associations for preterm births and low birth weight outcomes. And also American Indian and Alaska Native mothers also had the highest point estimates for preterm births, but because of smaller sample sizes, so wider confidence intervals. These disparities reflect cumulative environmental and social disadvantage. Next, please. And in addition to race and ethnicity, we also saw consistent social partnering, like mothers with lower education have stronger associations with preterm birth, and WIC participants also show greater vulnerability. And geographically, associations were more pronounced in Southern California rather than Northern, like where the exposure intensity and population density are both higher. This also highlights how wildfire health burdens not only reflect not only where smoke travels, but also where social vulnerability is concentrated. Yeah, next please. The last one. Yeah, okay. So in summary, basically wildfire smoke exposure during pregnancy is linked to increased risks of preterm birth outcomes and disrupted fetal growth. And communities already facing social and economic disadvantage bear a disproportionate burden. These findings underscore the need to incorporate pregnant populations into wildfire smoke reduction interventions, evacuation planning, and other climate health adaptation strategies. So ultimately, environmental justice must be a central thing to address since we are facing this problem of escalating wildfires, which is unavoidable, I guess. And that's it. Thank you.
Thank you. I'll remind the audience that they can put their questions into the Q&A while we wait for questions to come in. I was wondering, with the differential health impacts by these different population subgroups of the pregnant people, should I continue? I think I should give the others a chance because I get to ask lots of questions. Yes, I guess this is related to my question. I was wondering if you think that the differential impact is due to differential susceptibility, or do you think it's due to differential exposure that's not sufficiently captured by looking at solely outside exposure, like outside concentrations of wildfire smoke? And the question from Jake Fox is, do you account for maternal comorbidities? So asthma is one of the most common chronic diseases in pregnancy and may well influence susceptibility. So again, it asks that question about susceptibility. Do you look at that as a marker in your analysis of differential impacts?
Well, first of all, we did have maternal comorbidity data in birth records, but they are largely underreported, being most of the birth records data. So we tried sensitivity analysis with them, and they didn't really change our results. And also, we don't think they are the most comprehensive data to use. Also, we don't think they are critical confounders for this association. And then I guess this differential differences we see in the risk are partially due to the regions, like especially like the part and the exposure part is like the Native Americans actually are living in higher exposure areas, but Asians and Black subgroups were not. They were actually living, like their average exposure was actually lower compared to white, but they have higher risk.
Yeah.
So I think the using this exposure estimates only is problematic. Absolutely, for sure, problematic. But again, just back to what we talked about, like what the panelists talked about before, like it's very difficult to capture indoor exposures from the wildfires, like for now, especially at a large scale. So I guess it is an important next step.
Okay, great.
Yeah.
Thank you very much. Our next speaker is, and I apologize to anyone if I mispronounce your names. I'm going to Kelly Szott. Sorry about that. Whose talk is titled "The Effects of Wildfire on the Health and Social Support Networks of Rural Older Adults."
Hi, thank you. So I am a sociology professor coming at this from a little bit of a different disciplinary perspective and also looking at the post-fire effects. And this is my team that I worked with on this qualitative project. Next slide. So we looked at the Alameda fire in Southern Oregon, where I live. This is a picture that I took near my home. And it was a pretty catastrophic fire in 2020. Sometimes it is lumped together with the Labor Day fires. So you can see that a lot of residential structures were destroyed, many people were displaced, and the aging population was particularly impacted because several 55 and older housing communities, including mobile home parks, were completely destroyed. The fire was aided by a drought, a longstanding drought in the area, and high wind that day. And the whole area where we live is in the wildland-urban interface. So we are familiar with wildfires, but we were not expecting our town to catch on fire. Okay, next slide. So we know that rural areas can lack resources, particularly this can particularly impact the health effects on older adults. So social support networks are also, we know, very important for older aging individuals. And that we also looked at the concept in disaster studies of communitas and how that it's, just in a nutshell, it's solidarity forged through disaster response and recovery activities to see if that had helped with resilience among our participants. And I'll talk more about that. So next slide, please. Oops. So the methods, we conducted 20 qualitative interviews. 2 of them were Spanish speakers. Part of my team translated those interviews. They were conducted in 2022, which is 2 years after the fire. All of our study participants had lost their home in the fire. Okay, you can keep clicking through. I forgot about the animations that were in here. Here's average age. You can go to the next one. Average age 69, mostly white, mostly women, which is the whiteness is that it's proportionate to our area. Okay, next slide. So our findings, we definitely saw that post-fire housing was impacting the perceived mental health of the people that we interviewed. So you can see here from this comment from Virginia, the terrible insecurity of not knowing if and when or where you'll be able to find some place to live. Virginia had been placed in a hotel in a more urban area, away from her friends and former living community. Okay, next slide. I'm just going through the themes. This is the other theme we found, which was difficulty maintaining healthy behaviors. So the post-fire housing that people found typically was in hotels, or other spaces where there was no kitchen. So eating out happened a lot. People noticed significant weight gain. And also we had people report that they were smoking tobacco, cigarettes more often or restarted smoking due to stress. Next slide. And then this is where we saw a really big effect where people talked about the loss of their former housing community. And even in the case where people felt that their ties were rather weak, which is a sociological concept, maybe also in public health around the community cohesion being strengthened by weak ties, we noticed an emotional dimension to the loss of weak ties where people who lost their housing community, even if they didn't have strong relationships or didn't even know the last name of their neighbor, felt a very big sense of loss and sort of they were out of place. They lost their sense of belonging. And so we were, thinking in terms of the concept of communitas, and I needed to mention this earlier, but the COVID pandemic was also happening at this time, and this was before widespread access to vaccines, and so older adults were hesitant to go out and socialize. So this was a big piece of it. But also the post-disaster communitas didn't seem to build resilience or form among this community. So I think in part due to COVID, but also maybe this is specific to the aging community. So next slide. So yeah, just our conclusions: negative mental and physical health impacts were reported and connected to insecure housing and displacement, as well as the loss of one's housing community. Smoking and drinking was reported as increasing, and they were recognized by the interviewees as coping mechanisms for stress. Next slide. The formation of communitas was reported very sparingly among participants, and specific to wildfires, when an entire neighborhood is destroyed and people can't just come back and repair their home, or it's difficult for people to rebuild, or if they were renting, they can't come back. There's this loss of community that happens that is not tempered by communitas and is pretty a significant mental health issue for the participants in the study. Next slide. So for older adults exposed to fire disaster, response efforts should focus on housing quality and security. So security as in the sense of not having to move a lot, shift housing a lot. And also providing opportunities for creating and nurturing social bonds and networks, whether that's older social bonds or creating new ones, even if they're weak social links, they are significant to the participants in this. I think that's all I have. Yes, thank you. And we have an article that just got accepted for publication that goes through all of this.
Excellent. Thank you so much. Well, I don't see something in the Q&A yet. And I just wanted to ask a question. I'm so glad that this is about to be published because I want to cite it because I'm working on a similar project, but not with aging. But I was wondering, it was just a qualitative analysis of interviews after a fire, but I was wondering if you saw any, besides you looked for the comunitas as sort of, I think instead of a harm afterwards, but like a building of solidarity. I was wondering if you saw that there were some individuals for which the change after the fire, even if it didn't create comunitas, it had some beneficial sort of health impacts, whether that be through changing healthy behaviors for the better, if you saw any of that, or it didn't happen in this population.
I did not see that. I did see, interestingly, people go through a lot of mental health, like adverse impacts related to losing their community, but then gradually finding new community through Zoom support groups that were hosted by various like nonprofit and community organizations for fire survivors. So that did, but those people also like initially they struggled too. It wasn't like they found this group immediately and were like feeling okay. So yeah, I can't think of any other like positive impacts that I remember from the interviews.
Okay. Yeah, great. Thank you so much. We will move on because these are flash talks, but hopefully there will be some more questions put in the Q&A. The next talk is by Kristen, Cowan. Their talk is titled Wildfire Smoke Exposure and Risk of Hospitalization Among People Who Are Incarcerated in California and Oregon.
Thank you for having me. Yes, my talk is on wildfire smoke and health effects among people who are incarcerated. This was part of some of my dissertation work. Next slide, please. So we've talked a lot about wildfire smoke today, so just to situate you all to the population. I don't have time to go into a lot of the background on the whole issue of mass incarceration in the US, but for some context, more than 2 million people are incarcerated at any time in the United States. It'd be the size of like the third largest city in America. And these people are in all types of institutions like state prisons, local jails, immigration detention facilities, and all of these work under different systems, leading to a lot of folks being incarcerated. We also know that a lot of there are vast racial disparities in who's incarcerated. So the majority of people who are incarcerated in the US being Black males due to policing trends. So there's already big disparities in who's experiencing incarceration in the US. Next slide, please. And so how does wildfires add on to this issue? So this is just a quote here from an article in The Nation written by an incarcerated journalist called "Wildfires Are a Dire Threat to Incarcerated People Like Me." He says here in the part I highlighted, "We're usually trapped in poorly ventilated buildings. We cannot purchase air purifiers to make our living space more habitable. We cannot flee to somewhere safer for the weekend." So this really drives home the point of the lack of ability to really take any control or have any agency over what their environment is. So people who are incarcerated may be more highly exposed to wildfire smoke when there are wildfires, even hundreds of miles away from where they're incarcerated because of the lack of infrastructure to protect them. We also know this is compounded with a higher risk of chronic mental and physical health outcomes from the broad literature in public health on mass incarceration. And this is all further complicated by having less access to health care while incarcerated. Next slide, please. And you can just click through this. It has some animations, but I forgot you all would be doing this. So to summarize this point, we know that people who are in the general population are likely to have adverse health outcomes from wildfire smoke exposure. People who are incarcerated already have higher risks of adverse health outcomes and may be more highly exposed to wildfire smoke in their living situations. So we have hypothesized that there may be increased risks of poor health effects from wildfire smoke exposure during incarceration. Next slide, please. So to answer this, we wanted to, the objectives of this study was to determine associations between extent of wildfire smoke exposure and hospitalizations among incarcerated people in California for a range of causes, and Oregon for all-cause hospitalization due to sample size. And then we also, because we know that people might have lags in when they can get to the hospital when they're incarcerated, we wanted to estimate associations between wildfire smoke exposure and hospitalizations for more emergent conditions that can't be ignored or have a longer lag time. Next slide, please. And so we have a paper under review on this whole methodology to create this cohort right now. But just quickly summarize, we used electronic health record data from California and Oregon for the years 2010 to 2019. And we used a variety of factors in the electronic health record data, including ICD codes for incarceration. And to further expand the sensitivity of our population, we used variables like the source of admission and if they resided in a zip code that contains a prison or jail in it. Next slide, please. And then basically we linked in daily wildfire smoke, daily wildfire specific PM 2.5 at the zip code level and daily temperature mean at 4-kilometer grid cells for the dates of hospitalizations as well as the week preceding the hospitalization. Next slide, please. And as many other people have discussed today, we used a time-stratified case crossover design where we had all of our cases in the hospitalization data, and we created controls on the same day of the week within the same month. Next slide, please. And finally, we used a conditional logistic regression to estimate associations between daily wildfire smoke PM 2.5 and hospitalizations for all-cause respiratory-related, cardiovascular, and injury-related hospitalizations. Then, like I said, as kind of a sensitivity analysis, we looked at more emergent conditions within those categories, including MI, cardiac arrest, stroke, acute respiratory failure, and drug overdose, to kind of get around the known lag time in exhibiting some symptoms and getting to go to a hospital during incarceration. But due to small sample size, we were only able to look at all-cause hospitalizations in Oregon. We adjusted for daily mean temperature as well, and we looked at lags of 0 to 2, 3, 5, and 7 days for all of our outcomes. Next slide, please. And I'll just skip over the descriptive statistics for time. So these are our model results. So you can see in California, we had some surprise. California is the first row, and then the bottom row is Oregon. So you can see that's only on the left panel. That's all-cause hospitalizations. You can see we had some surprising results of the more protective effects in California between wildfire smoke exposure. This was for a 10-unit increase in PM 2.5 and hospitalizations, especially as lag time got longer. In Oregon, we did see increased risk, but we did not have the sample size for more narrow confidence intervals. Next slide, please. But then when we looked at our more emergent conditions, we saw similar protective effects for our cardiovascular related emergent conditions, but we did see increased risks of hospitalizations for short lag periods for acute respiratory failure and for our longer lag periods for overdose, which was an interesting finding to us and maybe showing that there's something there with the lag time. Next slide, please. You can skip this one too, thank you. And so just to kind of summarize, I think it's important to note that procedures around when someone gets to go to the hospital while they're incarcerated may be very different in this population than the rest of the population. So that led to a lot of these issues we encountered with this data. This study is limited to understanding the effects of outdoor air pollution and not indoor air pollution from wildfire smoke. And similarly, this work cannot draw any conclusions about wildland firefighters who are incarcerated, which is a very hot topic in media and everything right now. But this is more people who are experiencing wildfire smoke while incarcerated. And next slide, please. So to conclude, I think there's a need for a lot more future research looking into hospitalizations and healthcare access in prisons and jails, especially how indoor exposure assessment could really improve the way we're able to link in wildfire smoke exposure and other climate-related variables into this type of work. But overall, I think qualitative work examining behaviors around climate change in prisons and jails would really help with understanding what's at play here in a study like this. And final slide. These are all my acknowledgements, and I can answer any questions people have.
Thank you so much. As we wait for questions in the Q&A, I was wondering if you have any theories or interest in exploring why it might be that you saw those associations with overdose, with longer lag times, and I'm forgetting what the exact endpoint was for the shorter lag times on those emergent health outcomes.
Yeah, so the other one was acute respiratory failure, and I think respiratory associations are generally a shorter lag time with wildfire smoke in general in the full population. So I think that might just be a testament to, unless you're in like complete respiratory failure, there might not be options to go to the hospital for other conditions that we would see in the general population, and why in some of those like systematic reviews I had shown here but didn't have time to go over, in the general population we see 0-2 day and 0-3 day lags with like all types of respiratory hospitalizations, but maybe only the most extreme cases in this population. For the overdose is something I'm very interested in exploring more in the general population, as well as folks who are incarcerated in the future. I think there could be a few things at play, potentially changes in oversight and like just activities during incarceration when there's a like big wildfire event nearby that could lead to changes in drug use behaviors. But I think there also could be changes in mental health status, which we're not looking at here during these events, and also potentially like biological mechanisms at play. So I think there's a range of different ways that could be playing out. We're not sure what it is, so I'm hoping to do some future work potentially in the population of people who are incarcerated to look into that more.
Excellent. Thank you so much. And now we'll move on to the next talk by Yang Liu, and whose talk is titled Stroke Incidence and Long-Term Exposure to Smoke PM 2.5, a National Cohort Study in the US.
Thanks, Colleen. Can you hear me? Okay. So this work was led by Dr. Hua Hao, who's a research scientist in my group. Our paper will come out soon, and all the details will be presented there. So why do we care about stroke? Well, stroke is a major health burden in the United States, with roughly almost 800,000 new or recurrent cases every year, and about 140,000 deaths each year. It also carries a huge economic burden of nearly $40 billion per year. And stroke incidence among the elderly has decreased over the recent decades, but that trend has begun to plateau, which suggests that there might be some emerging risk factors influencing that trend. And we know that long-term exposure to ambient air pollution contributes to cardiovascular disease, but we have much less clarity on the stroke or any particular CVD impact of fire smoke PM 2.5 exposure. With wildfires becoming more frequent, and longer, and more intensive, understanding how long-term smoke exposure affects stroke, this kind of a severe cardiovascular conditions, has become increasingly important. So the objective of our study is to investigate the association between long-term wildfire smoke or wildland fire smoke, PM exposure, and the incident stroke among older US adults. Next slide, please. We constructed a national Medicare cohort from 2007 to 2018, and we applied a 3-year washout period to make sure we don't capture a lot of prevalent cases. After that process, the cohort includes about 24.7 million fee-for-service beneficiaries and nearly 3 million new stroke incidences. We also observed clear geographic patterns of the incidences, with high stroke incidences clustered in the southeastern US. For analysis, we used stratified Cox proportional hazard models and adjusted for a broad set of environmental, socioeconomic, and healthcare factors. And we conducted multiple sensitivity analyses, including a longer washout period, a shorter washout period, non-mover status, and then competing risk adjustments to test the robustness of our main results. Next slide, please. For exposure, we used daily estimates of wildfire smoke and non-smoke PM 2.5 concentrations at 1 kilometer resolution and aggregated them to the Medicare beneficiaries' residential zip code. We then constructed long-term exposure measures, including 1, 2, and 3-year moving averages, as well as metrics capturing the numbers of days with higher intensity smoke, greater than 1 or 2.5 micrograms per cubic meter per day, per year. I'm sorry. Across the cohort, the median 3-year average smoke exposure was about 0.43 micrograms per cubic meter, compared with about 8.23 micrograms per cubic meter for non-smoke PM. So in this study, the smoke contribution is only about 5% of the total PM 2.5 mass. Spatially, wildfire smoke exposures were highest in the west and parts of the southeast, including eastern Texas, and then the Georgia, Alabama, and northern Florida region, with occasional peaks above 2.5 micrograms per cubic meter. So in our study, the 2.5 microgram per cubic meter cutoff point corresponds to roughly the 95th percentile of our concentration distribution. So these metrics were designed to characterize both the average smoke burden and the frequency of more intense smoke days. Next slide, please. This figure summarizes the main finding of our study. Across 1, 2, and 3-year exposure windows, smoke PM 2.5 shows a consistent and increasing association with incident stroke. For the main result, which is the 3-year moving average exposure, each 1 microgram per cubic meter increase of PM 2.5 smoke PM 2.5 concentration corresponds to about 1.3% higher stroke risk, which is almost double the effect size observed for non-smoke PM 2.5 for the same change in concentration. We also see similar positive patterns when examining the frequency of high-intensity smoke days. So overall, these estimates suggest that long-term exposure to smoke PM 2.5 contributes substantially to stroke burden. And we can translate that risk to roughly 17,000 additional stroke cases per year among the Medicare beneficiary population. Next slide, please. In summary, our results show that long-term exposure to smoke PM 2.5 is a independent and significant contributor to stroke risks among older adults. So all our models actually control for non-smoke PM 2.5 exposure. So the effect size is consistently stronger than what we observed for non-smoke PM, which likely reflects the very different chemical composition of fire smoke, and then also the very different spatial patterns in how smoke is transported and deposited across the US. So the differences in the relative toxicity should be considered with caution, right? This is not strictly speaking comparing apples to apples. And looking ahead, as wildfires become more frequent and longer lasting, we need to realize that chronic smoke exposure will likely cause increasing CVD burden. It's not just a respiratory issue. And these findings point to a need for smoke-specific mitigation strategies. For example, targeted messaging for public awareness that closing your doors, closing your windows, and turn on a filtration is not just to make you comfortable for your throat. It could also lower your stroke risk. And then it also calls for protective guidance for the vulnerable populations. Next slide. Oh, I think that's all I have. Thank you.
Thank you. Again, please put your questions in the Q&A section, and we can ask all of our speakers any questions that happen to come along. I guess as a follow-up question, Yang, in the Medicare data set where you're looking at stroke incidence, are there other health endpoints that you plan to examine in a similar way?
We have looked at heart failure. So in the Medicare population, we only look at pretty severe conditions. Mm-hmm. Other people in my department also looked at Alzheimer's and dementia, and they also see some significant effects. Yeah. And then for respiratory, we looked at acute exposures.
And have you looked at differential impacts by demographic or other characteristics that could help understand who's most at risk?
We did, but I'm not sure it's consistent, or it really helped me understand the vulnerable population, because it varies quite a bit.
Okay. And there is one question in the Q&A now. It says, Dr. Liu, sorry I missed it. What was your study period? How many years?
So it's from 2007 to 2018. And with a 3-year washout period, really it's from 2010 to 2018. So 9 years of exposure.
All right. Well, unless I see any more questions come in, I want to thank all of our panelists. These were excellent talks. I found them all very interesting, and I'm sure that our audience did as well. And I'm so excited that so many of them are either already accepted or en route to being published, because it gives us more research to dive into more details and ask more questions. So thank you all for coming.
Yes, thank you all. And then just before we stop the broadcast, all of these recordings will be made available on the cafe website, as well as the slides. And of course, we're always open for any questions you have even after the event. Again, thanks to all the panelists, and thanks to Colleen Reid for moderating.